Hello and welcome everybody. I'm Anthony Gonzalez, he, him, and I am the program coordinator for the Higher Education Center for Alcohol and Drug Misuse Prevention and Recovery. And we want to welcome you all today to our webinar titled Supporting Students, the Connection Between Disordered Eating and AOD Recovery. Joining us today are our panelists, Tyler Rowling and Alex Shrode. Before we dive into today's content, I do just have a couple of housekeeping slides I'd like to review with everyone. Here on the screen should look somewhat familiar as we are in the Zoom webinar format. We do welcome your questions at any time today for our panelists. We do just ask that you utilize the Q&A feature so we don't lose them. We do have the chat enabled for today's session, so please use the chat to introduce yourself, share where you're joining us from, and any reflections or resources as it relates to today's content. But please, if you have specific questions for our panelists, just so we don't lose track of them, please try to utilize the Q&A feature. Additionally, if you have any audio issues or issues setting up the captioning, please send me a message and I'll be happy to help you through that process. We encourage everybody to learn more about becoming a member of the Higher Education Center. You can learn more about the different membership tiers and the benefits that go along with them by visiting our website at hecaod.osu.edu. We're also excited to share a couple of upcoming events that we have happening in the future. We have our second second session in the Grant Writing Learning Collaborative taking place next week on October 4th. We also have an October water cooler chat happening on October 10th and will be focused on high-risk holidays and will be facilitated by Dr. Jenny Damask. We also just announced our October webinar, which is titled Assisting Students in Recovery to Overcome Barriers, Lessons from a Campus Without a Collegiate Recovery Program, and will be taking place on October 19th and will be presented by Dr. Michael Broman. We also have the 2023 Cannabis Symposium happening on December 7th. We'll be releasing more information regarding session details in the coming weeks. We also have announced the save the date for our 2024 national meeting taking place here in Columbus, Ohio, July 30th through August 1st. And for those that can't join us in person, we will have a simultaneous virtual offering going on. And with that, it is my great pleasure to turn it over to our panelists today. Joining me today is Tyler Rowling, Health Promotion Specialist at San Diego State University, and Alex Shrode, Program Director of Eating Disorders Center for Collegiate Recovery Communities at Texas Tech University. Thank you for joining us, and it's my pleasure turning it over to our moderator today, Logan Davis.
Thanks so much, Anthony, and thanks so much to everyone who is here for this session. Very, very excited to have Alex and Tyler with us, and so really excited to kick this off and get started. And so welcome. So we do have questions that we have prepared, but we do want to hear questions from you. So to kick us off, Tyler and Alex are going to go through some brief slides and talk about the work that they've been doing in this space. And then so as they talk through the work, if you have questions, please put those in the Q&A. As Anthony said, we won't be able to keep up with them in the chat. So please put those in the Q&A. And lastly, thanks so much for being here. And thank you to Alex and Tyler for being here. And at this time, I'll turn it over to Tyler to get started.
Amazing. Thank you so much, Logan. It is such a pleasure to be here today on a topic that's very near and dear to my heart. And alongside Alex, it's just an incredible opportunity talking about supporting students and the connection between disordered eating and AOD recovery. So a little bit about the Wellbeing and Health Promotion Department at San Diego State University, where I work as a registered dietitian nutritionist and health promotion specialist. Some of the services that we provide include nutrition counseling, collegiate recovery, substance use prevention, AOD initiatives, sexual health, as well as sexual violence prevention. And we also included a link if you would like to check out our departmental info as well.
And I am Alex. I'm also a registered dietitian on the campus of Texas Tech. So we are a CRP, a collegiate recovery program for those who are familiar with that language. We offer specific recovery support for people who are in our program. So all of what's listed on the screen, as well as a recovery space for those who are maybe recovery curious on our campus. We offer a variety of meetings, 12-step and other types of all recovery meetings for those who maybe want to enter into recovery. And we kind of just walk them through that. So within that space, I focus on eating disorder work specifically, but also those who are just interested in emphasizing and increasing their wellness in recovery.
And so the objectives for today's presentation are going to be identifying the difference between disordered eating and eating disorders and what separates the two. We'll also be talking about the link between disordered eating and substance use disorder recovery, as well as learning current modalities that address disordered eating and discovering ways to foster community and fight stigma within these areas. So to kick us off, some definitions to differentiate between disordered eating and eating disorder. And really, disordered eating is more of a descriptive term. It's used to describe a range of irregular eating behaviors that might not meet the DSM-5 diagnostic criteria that eating disorders do. Oftentimes, eating disorders, disordered eating can be sort of subclinical, subthreshold to having an eating disorder. So there might be a range of behaviors that don't quite meet the diagnostic criteria. So here's a illustration to sort of show the range of behaviors that can exist, all the way from healthy body image, that includes things like body acceptance, healthy normal eating habits, a healthy weight for age, height, and body type. And then for disordered eating, you might see behaviors like restricting going on. Maybe there's yo-yo dieting, chronic dieting, any sort of laxative use or compulsive overeating or excessive exercise. But yet these behaviors don't quite meet the diagnostic criteria to be anorexic, to have anorexia nervosa, or bulimia nervosa, or binge eating disorder. And oftentimes as well, these symptoms of disordered eating, if left unchecked or not addressed, often develop into a more serious eating disorder. So some of the links between disordered eating and substance use disorder, there are shared characteristics. So for instance, both include a compulsive use or behavior. There might be a loss of control and continuing the behavior despite negative consequences. There's also common risk factors such as brain chemistry, family history, depression and anxiety, social pressures, as well as low self-esteem. So often we see an intersection here of disordered eating, eating disorders, as well as substance use, and we'll cover more of that as well. The screening is also similar for disordered eating, eating disorder, and substance use disorders. So it might be things such as, cravings, rituals, and obsession around an addictive behavior, giving up other interests to spend more time on an addictive behavior, inability to stop despite numerous attempts. Perhaps there's escalation and frequency and intensity over time, as well as continued use despite negative consequences. Is there anything else you want to add to that, Alex?
I think a lot of times we see the link to, I see it a lot with preoccupation, right? So kind of going along with the cravings, like just being preoccupied. So what I tell friends and family about, how to kind of watch for these things or look at these things is, what are their conversations about, right? What are their searches about on their browsers, on their phones or whatever? Just kind of like that preoccupation with the focus on food or body image. And I do want to point, someone did put in the chat, ARFID and atypical anorexia. Yes, those do fall under, those are Also diagnosable eating disorders. ARFID is a relatively new category of eating disorders that don't have a body image preoccupation. So I think probably in the context of today's conversation, we probably won't be addressing. And then I will continue to talk about atypical anorexia a little bit later, because in my work and what I've seen on our campus, I'm seeing that more and more. It's probably the majority of the people that I work with. So thank you for also including those, because those are just as important and deserve just as much recognition.
Okay, so some statistics to consider when we think about the intersection of disordered eating, eating disorders, and substance use disorders is 20 to 67% of college students experience some sort of sub-threshold eating disorder symptoms, so not yet quite diagnosed with an eating disorder, also known as disordered eating. Up to 35% of individuals who are dependent on alcohol or other drugs also had eating disorders. Up to 50% of individuals with eating disorders abused alcohol or illicit drugs, and also individuals who abuse alcohol or illicit drugs are up to 11 times likelier to have some sort of eating disorder. So we can see, just based off statistics alone, that these two worlds collide. And so it's important to have conversation around it, and ways that we can best support students. So this is from the National Center on Addiction and Substance Abuse at Columbia University, talking about common substances that you will see in individuals with eating disorders. And that might include substances such as caffeine, tobacco, nicotine, alcohol, laxatives, and diuretics, appetite suppressants, also known as amphetamines, heroin, cocaine. And what you notice about some of these substances is that a lot of them do suppress appetite on some level. So we know caffeine, nicotine, amphetamines, cocaine, these all suppress appetite, which can trigger eating disorder, as well as other substances like alcohol or laxatives. Would you like to add something, Alex? I see you reaching your hand. Okay.
Nope, sorry, you're doing great.
All right. And another topic that is important to address within the college population is something that is referred to as food and alcohol disturbance, or FAD. The colloquial term that we often hear is drunkorexia. And this is the use of compensatory behaviors to offset any caloric intake from alcohol, but also to potentially get drunker faster or enhance the intoxication effects. And there have been studies that show that alcohol misuse and disordered eating often co-occur within the college population, and rates of this behavior have been documented as high as 57.7%. So it is a topic to address as far as, okay, how can we begin to have these conversations around harm reduction and talking about the importance of eating, for instance, when it comes to drinking behaviors, as well as screening for any potential co-occurring disorders that might be taking place with excessive alcohol consumption or binge drinking or any sort of substance use.
So the current treatment field right now has a lot of shift to virtual options, right? And I think that's probably something that we're all pretty familiar with right now. So when it comes to treatment for eating disorders specifically, or if there's a co-occurring eating disorder and substance use disorder, the same levels of treatment also prevail with eating disorders that it does with substance use. So, well, there's not a detox unless they need that from a medical standpoint. But there can be some sort of hospitalization to just kind of check their physical health, residential, inpatient, IOP, all of those things, similar to a lot of the trajectory of substance use recovery. So just like in other areas, there's a large shift to virtual options, which makes it really tricky with eating disorders, because we want to see these people eating, we want to monitor, we want to have that oversight. So while that has been a really beneficial thing for a lot of people when they're, needing support, and maybe they live in a rural area or they don't have the time or the resources to get to treatment, there's also a little bit of there's some complexities that need to be addressed for sure. So when we're talking about like the actual therapeutic models, Maudsley or the family-based treatment still remains remains the gold standard for adolescents, right? We want to involve the family. We want to make sure the family system is healthy and supportive and all of those things. And then the older someone gets, if they have anorexia and bulimia, which I forgot to put on the slide, CBTF, which is CBT focused, is really, really effective. So CBT being, replacing those thoughts, a lot of mindfulness, and being really tuned in. There's a lot of other effective modalities that have been studied for eating disorders. They do pinpoint anorexia and bulimia as the most studied, right? So our friends that have atypical anorexia or fall under the category of OSFED, there's so many acronyms in eating disorders, you guys, so try not to keep up with those. But atypical anorexia, like we talked about earlier, or RFID or binge eating disorder, haven't been studied as widely yet, right? So we are still learning what the most effective modalities are for those. When it comes to the eating side of it, my personal preference as a dietitian is to help people eat, period, right? And I think that's probably, I hope Tyler would agree with that, that's probably a general consensus from the dietary field of like, it is really hard to enter eating disorder recovery and maintain eating disorder recovery if you're not eating, right? We know that from a physical standpoint, we know that from a brain standpoint, and now we know that from a recovery standpoint. So we'll continue to talk about intuitive eating, which is one of the premises of recovery. And sometimes that's really difficult in our intersectionality population, right? That's really difficult for people who have struggled with substances and maybe aren't able to identify those cues, which I'll continue to talk about here in a minute. So I think connection is one of the things that kind of overlaps with AOD recovery, right? We know that connection is really important. A lot of times people say the opposite of addiction is connection, right? Recovery is connection, all of those things. And it's vital for people. I think that's probably, in my very small opinion, why the family-based system is so successful for young people who are struggling with eating disorders, right? Just that connection, that support. We know that isolation is super, super harmful for people who are struggling with any sort of mental health issue. There was a study done in 2012, and there were a couple of other studies that supported this as well, that what aids recovery, right, in eating disorder specifically is reconnection, so reestablishing relationships, especially the closer the relationships are to you, right, whether it is someone in your family system or maybe someone that is very close to your family system if they're not directly related. Empathy and compassion, which in my opinion seems to be some of the antidote for the negative connotation that we have with eating disorders, right? That eating disorder voice that our friends hear when they have an eating disorder, that empathy and compassion and really cultivating that seems to be really beneficial for them in their recovery. And then provider rapport. Provider rapport is probably, I actually think it's studied as one of the #1 indicators of success for someone in the recovery journey, is how well are they connected to their providers, right? Anyone that they're coming in contact to that they're working with for their recovery. Are their doctors compassionate and understanding and hopefully weight neutral, right? That's a whole other topic, but hopefully weight neutral. Is their dietitian understanding and compassionate and, not super rigid, like a lot of people think we are, but we're actually not. Are we not being the food police like they think we are? Is there a therapist really compassionate and understanding and just kind of helping them figure these things out? So provider rapport is absolutely crucial when it comes to eating disorder recovery, very similar to AOD recovery, right? We want all of those same characteristics in any provider that we're having for those who are struggling with substances. Things that hinder recovery or more likely to hinder recovery are, trivializing the disorder. So playing it down. Oh, it's not that big of a deal. Oh, just eat. Oh, just don't eat, right? All of the trivializing and harmful things that we hear regarding food. Hyper focus on eating, right? A lot of times it's scary when we start to think about eating disorders and the negative impacts that they can have on ourselves as a whole. And so it's really easy to focus on the food. But in our viewpoint of this, food is not the problem. just like drugs and alcohol aren't the problem, they are symptoms of the problem, right? So hyper focusing on those things can be really, really problematic and cause a lot of friction in our relationship. Miscommunication, obviously, that's a hindrance to a lot of things in our world, but especially regarding food, right? We want to be specific and understanding, but not so specific that we encourage rigidity. Stereotyping and stigmatizing, I think that's really where the atypical anorexia piece is important, right? We want to have providers that are really neutral, really, really understanding, and have a good, in my opinion, a good identification of the research regarding weight neutrality, right? We want them to not be patronizing and understand maybe some of the genetics behind people's bodies and how that plays out in their medical health. And then weight. Using weight as a recovery barometer is extremely common in the initial stages of recovery. And I understand that from a physical standpoint, we have certain mechanisms in our body that just don't operate well or function optimally without a certain amount of pounds on our frame, right? But using that as a sole barometer of our recovery at times can be hindering, right? It can be difficult, especially if we're working maybe with a young person population, we're working with college age populations, or even slightly older college age. We in our program have a lot of non-traditional students, and we still even see this, that our weights change as we get older, right? I think probably most people would agree with me on that. I certainly am not the weight I was in college, and I am certainly probably not the weight I'm going to be in about 10 years. And that's normal. That's a natural part of life, right? So using weight, one specific number, as a recovery barometer can be really harmful to people when they're trying to learn that flexibility and trying to understand their own body a little bit better. Tyler, anything you want to add to that?
I was just going to say, yeah, that the importance of having the conversation and sort of fighting some of those stigmas that do exist around eating disorders, which I know we're going to talk about in the following slides, and how we can begin to foster those communities to start having conversations where it's not just white cis female that struggles with perhaps disordered eating or substance use, and actually creating that sense of spaces for students to connect and belong.
Yeah, absolutely. And so I think if it's okay with y'all, there was a question about so I'll read the question. Do you have a comment about how treatment and recovery models for SUDs follow paradigms set by and for cis straight white men, given the gendered social dynamics around eating disorders? So much like other treatment modalities, eating disorders are no different. The majority of research has actually been on cis straight white females, right? And more so adolescent females. So when we talk about, the modalities and what's been the best, the gold standard right now, that is what we're projecting it towards. And so another connection that's really, really important in eating disorders is the connection between eating disorders and food insecurity, right? And so we want to be really, really careful in understanding and have a very large amount of cultural competence when we're talking about, what did food look like for you? What does it feel like to live in your body, right? The saying that I like to use is, your body is your home. Tell me about your home. What is that like for you? And so just having that's why I say compassion and empathy is probably one of the bigger undertones of this work, is understanding, like, I know what the research is saying and what the research was intended for. And here is where that lived experience comes in, right? Just like in AOD recovery, you are the author of your life. You tell us what it feels like to be in that home. And so really, really, really having conversations that are focused on that, I think, can help kind of start to break those barriers that we've seen in treatment, right? And hopefully, I'm not a researcher. I'm a boots on the ground kind of person. I'm a clinician, right? Hopefully the research tends to follow that lived experience. So intuitive eating is the, again, gold standard, right? I don't have another phrase for that, you guys. That's why I keep saying it. It is the thing that you will hear most when you're talking about eating disorder recovery and registered dietitians and the dietary food aspect of it. Now, I will say, as a disclaimer, I am a very, very big proponent of intuitive eating. I think it is such a difficult thing to do, you guys. It's so, so difficult So intuitive eating is also very commonly misunderstood, right? And in a minute, I'll talk about interoception, which is the new fancy word that's coming out, and a lot of research is being done on it, and it's really cool. And we'll talk about how that is so difficult to kind of mirror these two together. So intuitive eating is a theory really based on 10 principles relating to rejecting the diet mentality, diet culture, discussing hunger, fullness, challenging the food police or those eating disorder thoughts that we hear, satisfaction, fullness, coping with your emotions with kindness or appropriately. It used to be without food and they changed it to kindness. I thought that was great. You know, all of these obviously very, very good principles that kind of go along with, you know, how do we learn to eat? Now, intuitive eating is not where you start when you're entering eating disorder recovery. And I think that's one of the things that's most misunderstood. When people are entering recovery, whether they have just eating disorders or alcohol and drug or a combination or whatever, we do not start with intuitive eating. That is such a scary concept, right? And so we start with a plan of some sort. Let's figure out how to get some consistency. Let's figure out how to get some adequacy. Let's figure out how to time your meals. Let's figure out how to have, I call them components, other people call them exchanges, or, you know, let's figure out how to get the nutrition in your body that you need and sustain that. And then we will learn some flexibility and some intuition. And when I start to talk about intuitive eating, Tyler, I don't know if you have the same experience, but when I start to talk about it with people, they're like, what do you mean I can eat whatever I want? Well, that's so interesting. That's not what I said, right? I mean, you can because you have that autonomy and that authority over your life, but that's so interesting that that's not exactly what I said. So it takes a very long time for intuitive eating principles to be really honed in, and they change with, you know, all of our lives are, everyone's lives are different and crazy and busy and then slow and then not. So it takes a long time to really let these principles be part of your recovery and not the soul of your recovery. Anything else you want to add on intuitive eating, Tyler? Like I said, big fan, but it's a very long work in progress.
Yeah, no, I completely agree. And it can be really dysregulating if someone is in the midst of an eating disorder and overwhelm leading to just confusion and inaction. And so really fostering that sense of safety with food and that regularity with your relationship to food is important. And then intuitive eating sort of builds on those principles once that feeling of safety is really cultivated, and trust with the self begins to be cultivated too. And I always like to think of intuitive eating, you can describe it as it works in two ways. The first way is to help cultivate interoceptive awareness, which we're going to talk about in a moment. And then it helps to remove any obstacles that might be blocking your ability to perceive bodily sensations. So it's really creating that bridge, the mind body, to connect the two. But again, it's not the thing that you jump into right away. But it is for those students in my experience who don't have an eating disorder and it's more disordered eating going on, but they haven't been diagnosed with anything, it's not as extreme. Intuitive eating can be a great approach for them, an intervention to hopefully begin to target some of those negative beliefs that are starting to form around food and body image. So just wanted to add that too.
Yeah, great. Good. I'm so glad you mentioned safety because, I mean, it's, if you're, you know, I'll use some clinician terms here. If you are upregulated, it is really hard to learn safety, right? If we're in fight or flight, we're going to want to go for the foods that sustain us when we're in fight or flight. And that might not feel like we're honoring intuitive eating when we do that, but absolutely it is, right? So this is how those can be commonly misunderstood, and it feels a little bit maybe chaotic and less controlling than some of the eating disorder or disordered eating behaviors. Good point. Excuse me. So interoceptive awareness is, like I said, newer word, but not newer concept, I think, if that's how I'm kind of understanding that one word. The word itself tricks me, right? I get confused between interoceptive and intuition all the time, and they can be seen similarly, I think. So interoceptive is your internal cues, right? So hunger, thirst, feelings, any of the feelings, anger, rage that we feel, like under our skin, anxiety that makes our bodies kind of twitch and we want to bite our nails, sleepiness, right? I read something the other day that interoception is even when our noses are stuffy, right? I have a toddler. Shout out to parents of toddlers. We're barely making it out there. And her nose is stuffy, right? And I was trying to get her to blow her nose. And if anyone has ever tried to teach someone how to blow their nose, it's exhausting. It's infuriating, right? Trying to help someone learn how they feel hunger can be a similar process, right? But they're all interoceptive cues that our body sends us, right, to have this experience, right? I have a stuffy nose for whatever reason, and the cue is going to be uncomfortable, right? Up here, we have some sinus pressure in hopes that I will blow my nose, right? Similar to hunger, I have a hunger cue. It's going to start, a number of ways. Maybe I get kind of foggy. Maybe I get hungry and I feel it in my stomach. Maybe I feel it in my mouth. My mouth starts watering when I start thinking of food. Maybe I have a headache and I'm grumpy and I'm just dragging and I'm slow, right? In hopes that my body will get some food, right? So interoceptive cues should be linked to action, right? They should be linked to some kind of action that prompts us to do something. Now, the tricky thing with this population that combines AOD and eating disorders is that substances greatly interrupt our interoceptive awareness, right? Alcohol, for one, greatly overrides the hippocampus, where we get a lot of hunger and fullness cues, right? That's part of the reason that the drunkorexia or the fad that we talked about earlier is so problematic, because when we all have that first drink, right? For the first 1 to 3 drinks, we're like, oh, where's Whataburger, right? I'm so hungry. But the longer you do that and the more you override, the more likely you are to not eat at all, right? And so anyone who has worked with someone who struggles with alcohol use disorder, the longer you have worked with someone in there, the more you see malnutrition because they have not been eating for a consistent amount of time, right? Because that interoceptive cue is completely overridden. Similar to amphetamines, right? Yes, they do suppress the appetite, but over time, once you hopefully stop using alcohol or other drugs, we do see this huge revamp in cues, right? And so a lot of times, I used to work in substance use disorder treatment. I would get clients that would be like, why am I starving? And I'm like, yes, good. Eat. We want those cues to return. Even if they don't return comfortably, even if they don't return slowly, we want the body to do what it, was designed to do and restore those nutrients by way of eating. And so substances can greatly interact how interoceptive cues play out in our lives. Restriction and binging can kind of also interrupt that pattern, right? When we're restricting for a long amount of time, we do have a decrease in hunger, and that's very problematic because I'm sure Tyler gets told this all the time, but I don't feel hungry. Right. Of course not. You haven't been eating. You're not going to feel hunger, right? We need to rely on something called mechanical eating, where we just get that pattern down before we have the intuitive eating, right? Like I said earlier, trauma can also help us detach from our body, right? That lack of safety. And really, I had someone who told me, it was one of the best quotes I've ever heard. This person said, I wish I was just a floating head, right? Of course, right? That's how trauma or substances or even neurodivergence kind of play out, where we don't want our brain and our bodies to connect, right? That's really, really difficult to do on a day in and day out basis. And so all of those things can interrupt any of the interoception that we're feeling in our body, making it harder to eat on a consistent basis. And then sometimes making it harder to know, was that enough? Should I stop? Should I not? Do I need more? So it's a very, very consistent target in eating disorder recovery. And it does, just like everything else I've said, it takes time and it does change, right? If you're starting your eating disorder recovery journey as a young adult and you are, I don't know, single, no kids, you decide to go to college, great, you will figure that out. Fast forward 5 to 10 years, I bet your life looks pretty different. And we're going to have to figure out, what those interoceptive targets look like there too, right? So it's a very crucial and consistent target when we're doing this work over a long period of time. So when we're talking about campus resources or even just any community resource, the most important thing I think any individual can do and see you do if you're someone who wants to foster healthy communities and healthy eating relationships is eat. There is nothing more important than actually putting fork or spoon to mouth than chewing and swallowing, and letting them see you eat a variety of foods, right? You know, if you are I'm not a vegetarian, but if I was a vegetarian, I would hope that they would see me eat a variety of foods, right? Including, I don't know, maybe salads or pasta or pizza or Asian food or whatever food is your jam, right? Just letting them see you normalize food is one of the healthiest things that you can do for individuals who are struggling with food. We here at the Center for Collegiate Recovery offer community lunches, and we try to make that a variety of foods. And sure, we get the normal flack about, you know, my goodness, pizza, blah, 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 and their ideas of pizza. But I have hopefully established a premise in this community that, first of all, you know, you're welcome for the pizza. Gratitude goes a really long way when it comes to food. And second of all, yeah, pizza's great. Pizza's a wonderful food. And, you know, I have no qualms about eating pizza because I trust my body, right? I have established that sense of trust within my body. And if you're struggling to do that, I want to help you do the same thing. So just really, really being aware of diet talk, really being aware of, you know, negative connotations around any kind of food or the way that anyone looks, or even just those, you know, we want to be very aware of even how we're talking about certain populations with food, right? I mentioned earlier the connection between eating disorders and food insecurity. We want to be really, really aware of, you know, if someone needs assistance getting food, we want to be supportive and compassionate and understanding regarding that. We don't want to have any preconceived notions of what that's like, because the majority of people who are in college are struggling to get enough food anyways. And so we want to be understanding of the resources that are available to us, but we also want to be, you know, supportive and connecting them to those resources. I think it's always important to address potentially problematic courses, kinesiology, or any kind of like health and wellness, nutrition courses, psychology, any kind of counseling program, things like that, where we might have these conversations start to come up about eating disorders or food or body, and then going in and saying, hey, here's a resource for you guys. You know, I'm not here to change your course curriculum, but I'm just here to provide a resource if you might have a student who is struggling. Meeting with and making connections to anyone and everyone, shouting from the rooftops, we have this resource here, or I am here to foster healthy communication, or foster a space for people that is not diety and non-judgmental and super awesome. You know, it's making a lot of connections, putting a lot out there is one way to kind of help build these healthy communities, whether it's on campus or in your community. And then if you have the space, we're very, very fortunate to have a space to have meetings, right? We have space for Eating Disorders Anonymous meetings. We have space for all recovery meetings. We have space for a behavioral meeting that occurs with a clinician. And so if you have the space, offer it up, right? To connect with someone who might be willing to lead the group, but maybe offer your space. Those are just a few ways that we've done it here on our campus. Tyler, what does it look like at San Diego State?
Yeah, that I think it's actually on the next slide, some examples. I'll just switch over to that. Totally agree with everything Alex said as far as fostering those on campus and also off campus partnerships. Really being able to be that bridge to connect students to the resources that they need, and fostering those communities, whether it's through support groups. We partner a lot with counseling and psychological services. I get a lot of referrals from them. Part of my role within the department is providing one-on-one nutrition counseling. Our department doesn't offer long-term care for eating disorder recovery. That's when we refer off campus. However, we do offer sessions on intuitive eating and nutrition for those who might have any sort of disordered eating symptoms going on. Counseling and psychological services created a group called Body Wisdom. This is based off of Be Body Positive. It also includes principles on intuitive eating and creating an inclusive group for students to come together to talk about some of these topics. We also do campus events around National Eating Disorder Awareness Week. So often a big part of our role, as we know, is not just staying within our offices, but getting out on campus and meeting students where they're at and letting students actually know about our services. I think that's one of the biggest challenges that we often have, is like, how can we let more students know that we exist? And like Alex said, just shouting it at the rooftops, right? And so being able to go out in public and have these events where it's, you know, see the change, be the change. We talk about eating disorder statistics. We talk about screening for eating disorders. We talk about ways that you can support those who you might suspect has an eating disorder. We talk about on-campus resources, whether it's counseling and psychological services, one-on-one nutrition counseling, as well as any off-campus resources and providers. We also have a health literacy coordinator, someone who can help a student navigate their insurance. So if they're having difficulty connecting to a provider, then we have individuals who specifically help students get connected with the support that they need. We also have something called Recovery at State, which is recovery support for students based off of the SMART recovery model. And this is an excellent resource for students, anyone who might be navigating any sort of compulsive behavior or addiction or misuse with substances. And it's really used as a model to raise awareness and combat stigma. And again, connect students to resources. So those are just some examples of what we're doing at our university. And I also saw in the chat here, and I just wanted to address it around gentle nutrition. Oh, you got it, Alex. Awesome. Okay, I see that. I was going to answer that. Okay. Alex, was there anything that you wanted to add?
No, I think sounds like San Diego State is doing a lot of things, thankfully, and similarly to Texas Tech, in that I think a lot of however your system, right, whether it's a campus, a community organization, a school, whatever, however it's organized, I think making sure I very much agree with the like top-down method, but I'm actually more of a fan of the bottom-up method, right? So something that we've done here when we're talking about recovery in general, whether it's eating disorder or AOD recovery, is we go to the people who are seeing the students first. And yes, there's a lot of turnover in that, right? But we go there first, and then we slowly work our way up. We kind of make ourselves known. We try to be really, you know, squeaky wheel cheese situation of letting people know that there are resources and there are people who are willing to listen. And I think one of the things that we've had on our campus and in our program is, one of the things that I've been told, unfortunately so, is, you know, we don't have a lot of eating disorders on our campus. And I think because we might not have a lot of diagnosed eating disorders on our campus, or because we're not all walking around with a t-shirt that says I have an eating disorder or whatever it is, there's obviously a lot of misconception. There's obviously a lot of ignorance, if I'm being honest. And so I think letting people know that it doesn't look like you think it does, it doesn't sound like you think it does. And we really, really, really need to do a lot of internal work when we're looking at, like, okay, what is my opinion on eating disorders? What am I thinking it looks like? What is my opinion on weight and body sizes and behaviors, right? And look at it through that lens. And especially, you know, a harm reduction lens is your jam. That is a great way to look at it, right? And so just being very aware of that. Again, I like to start at the bottom and talk to the people who are talking to the students first, and then work my way up and show examples of this and hopefully help people do that. One of the programs that we've implemented here for AOD recovery is Recovery Ally, but I think that it's a program that could very easily be translated into eating disorder prevention and eating disorder awareness. Just kind of, you know, how do you be an ally for someone who claims eating disorder recovery, or how do you be an ally for someone who is actively working on their relationship with food, and understanding that it's so nuanced, right? It's not going to be black and white, like I'm done today or I was done yesterday, or just kind of, you know, similar to like we see with a lot of students in recovery from substances, you know, claiming a dry date, maybe, or having a day that they stopped using substances, or having a day that they started decreasing substances. It's going to look a little bit different, and understanding that nuance, I think, can go a long way. I see a couple of questions. Do you want to tackle them, Tyler? Do you want me to tackle them?
Go for it.
So I'm just gonna try to go in the order that I saw them, if that's okay. So we offer an all recovery meeting for students, but the expertise in the room is very much focused on substance use. Same. We have a similar. I don't want to call it an issue, but a similar situation. Do you have advice for engaging students in ED recovery without claiming authority on that topic, and then finding literature or meeting topics that are inclusive of ED recovery? Tyler, you mentioned y'all have smart recovery, and I think that's a wonderful way. Smart recovery is based in CBT, which I mentioned is a popular and effective modality for eating disorder recovery. And I think that's often a meeting topic that people really appreciate, because also with our friends who struggle with disordered eating and eating disorders, they want to do something, right? They want to do something, and smart recovery offers you that. So I think that's often one of the ways we can do that. And then it is interesting when you have a mix of people in an all recovery meeting. We just encountered this a few days ago. Finding we never want to in an all recovery meeting for us, we don't ever force anyone to identify in any way that they're not welcome to identifying or willing or ready. And so we talk about, when it comes to your behaviors, we talk about intentions, right? What are your intentions? I call it the magic question. What is your intention, right? What's your intention with using alcohol? What is your intention with restricting, right? Or whatever behavior. We use the word behavior a lot, just so that people who might not be willing and ready to talk about it a little bit, or who aren't ready to claim authority on it, are able to answer that confidently. I'm using my behavior because I am so stressed, right? I'm so stressed, and that behavior really helps me feel like I'm in control. Whatever that actual behavior is their business, right? And I think that's kind of laying that out in the format of the meeting can be really helpful sometimes, and expressing, like, there might be people, maybe there are people who have different behaviors all in one setting, right? And maybe they're using a variety of behaviors on a week to week basis, and we want to be inclusive of those too, right? Maybe they're using, I don't know, people, right? Maybe sex and love is something that's really problematic for them, and they're also using those things to kind of change how they feel. So just being really intentional in the formatting has seemed to be beneficial for us here at the center. Tyler, do you have anything on the literature or meeting topics that, other than smart recovery? And I'm trying to think of the one that we used the other day.
When the Be Body Positive is something that counseling and psychological services focuses on, although it's not related directly to substance use, what it does address is beliefs around body image, beliefs around food, and being able to really unravel some of those stories and change those negative beliefs, which I know CBT, that's their focus as well. So Be Body Positive is another curriculum that has been shown to be useful in preventing more maladaptive behaviors around food and body image as well.
Okay, that's good.
All right.
You just keep going.
Yes.
Okay, any suggestions on how to engage students in practicing substance use reduction or increasing awareness that the substance is problematic? I've encountered lots of resistance from young adults who seem worried about the ED, but not the substance use. I think that's a great question. I think making that overlap and asking clearly a lot is like, okay, well, how are they alike and how are they different? And just really maybe making them similar in that sense of, like, what are they both doing for you? What would happen? A lot of motivational interviewing is really, really key in that, right? Like, what would happen if we didn't do this one? What would happen if we didn't do this one? Right. And just kind of continuing to talk that out. And I think what's hard for us to, at least for me as a clinician, I'll say, and other clinicians that I've workshopped this with, is that we get really worried about the substance use, of course. And so we want to be really quick to be like, the substance use isn't helping. The substance use isn't helping, right? And we want to, it's not helping, it's not helping. And we get concerned and worried, right? And so I think slowing it down a little bit and really allowing them this space to figure that out on their own is going to be really, really beneficial. Obviously, that rapport is going to matter, right? If we're coming at it from a sense of like, these are always your choices, this is all your autonomy, right? Autonomy is huge in eating disorder recovery, and I think it's huge in all forms of recovery, of like, this is your autonomy, and I'm going to lay it out what it kind of looks like, right? This is kind of some of the things that we talk about with continuing to use substances or continuing with eating disorder behaviors. This is what we want to be aware of, and I just kind of want to know where you stand on that, right? Really taking maybe a compassionate and understanding point of view on that can hopefully be helpful. I think that's a really, really tricky topic, though, especially, young adults or students who are not in long-term counseling, right? A lot of us have short-term models that we're working on, so we do have limited amount of time, and yeah, it can be really, really tricky. I think peer support, right? If you have a peer support group or an all recovery meeting that they can attend or something like that can also be really, really helpful.
And I'll just add too, I think understanding, you mentioned this too, Alex, sort of the root of like where the behavior is coming from, because understanding that perhaps the eating disorder behaviors might be stemming from this sense of wanting to control. Maybe they're experiencing symptoms of anxiety, depression, or sort of obsessive compulsive behaviors. Versus with substance use, maybe it's this more reward system that's happening and dopamine. And so really trying to understand what is triggering the behavior as well, I think was important too.
Good. Tyler, do you want to take the next one that's in the
Sure. So what is it called when someone is using their eating disorder as a form of self-harm? So again, there's so much nuance to eating disorder, whether it's a form of control or dissociation and not wanting to really connect to the body. We also know that eating disorders, if there's a history of trauma, or depression and anxiety, and self-harm being this dissociative sort of state, right? To not necessarily feel what's happening, that actually led to the eating disorder. So again, when working with students and this population, really trying to understand beyond just the surface behavior of what's happening, but really trying to gain an understanding of what might be happening underneath, and recognizing that often self-harm is connected to dissociating. Alex, did you want to add anything to that?
No, that's exactly where I would have gone with it, is just how important regulation is, right? And just kind of understanding. I completely agree with the dissociating and not wanting to connect to your body, right? It's very frightening for a lot of people to be, like I said earlier, your body is your home. And so it's really frightening to be in that home for some people. And so realizing that, maybe harming that home in a sense, right? If it's some behavior that they might see as harmful, then that's the interesting thing is, when you talk to people about these eating disorders, some will tell you like, I know it's not a problem for me. It is fine. And some will be like, I know exactly what I'm doing and why I'm doing it. Right. And just talking to them about like, how are you caring for your home and just how do you live in your home, and having those body-centered conversations is kind of one way to address that. I will say, I don't know if there's not an actual phrase for what it's called, or not an actual diagnosis for what it's called when someone uses it as a form of self-harm, but it is a very common practice.
The next question, what are your thoughts or opinions on 12-step recovery? There are numerous 12-step programs related to food and eating recovery. And based on the research that I've read, 12-step programs can be great in addition to therapy. Not necessarily standalone, although that might work for some people. But again, thinking of like the holistic model, when you think about recovery, like 12 steps would be great in conjunction with also seeking a therapist and working on modalities like CBT or dialectical behavioral therapy is another popular one that's popping up as well. So that would be my answer to that question. Alex, did you want to add anything?
I do. This is a common question that I get, because where I live in Texas, love Texas. Thank you for loving Texas, everybody. We are a very 12-step heavy area, and so we get a variety of 12-step. You know, you have your EDA, you have your OA, you have your ANA, and we are here where I work. We are happy to host any type of 12-step meeting that is beneficial to our community. Right? We let our community decide that. And we're happy to provide the space. I have worked with a number of people who have been on completely opposite ends of the spectrum, where 12-step recovery, whether it was an EDA or an OA or whatever, was what helped fuel their recovery further. And I have been on the other side of the conversation where it completely hampered their recovery, right? And so I say, you know, again, your home, you figure it out. You tell me how I can help you with your home, right? How I can help you figure out how to continue to live in your body. I think that's something that as a clinician, it took me quite a while to realize, or as someone who is interested in being person-centered when I'm doing work, is I am not here to tell you exactly what the research says and to make your recovery look one way. I am here to listen to you and help you and support you in your recovery in whatever way that feels beneficial to you. And so if you have worked on this for a number of years, and, you know, outside of your little interaction with me, you're going to continue to have to work on this, you know, for hopefully forever. And you tell me that OA is the program for you, you know, or not having sugar in your house is the way for you. I think that is your business, right? And I don't have the authority on that. I agree. Someone put in the chat, I think it depends on the groups. Some groups still have internalized fat phobia and promote restriction. Other groups are more informed on intuitive eating. I completely agree. Traditionally, like OA does promote restriction, right? They have their 4 foods or food groups that you don't eat. And so is it the first choice that I'm making? No, I completely agree with what Tyler said. You know, in addition to it might be beneficial to seek out other forms of support. So I think that's a really interesting topic. So more to be discussed about that for sure. I could probably talk on that for another 20 minutes or so. So we had one last question on books and podcasts, or I think just books. I will say there's a lot of podcasts, right? I just wanted to make a really quick plug for that, because I know we're running out of time. Tyler, I don't know if you have any specific books that you could shout out real quick. Mm-hmm. I'm a really big fan of Maintenance Phase for a podcast, a really big fan of, I forgot Christy Harrison's, her name is Christy Harrison, but I can't think of her actual podcast. Thank you. There thankfully are there are more resources than ever. Can you list some books? I can't think of any books right now off the top of my, I'm sure I could turn around and look at my
Yeah, there's a book published by it's called Co-Occurring Mental Illness and Substance Use Disorders, A Guide to Diagnosis and Treatment. And it specifically addresses some of those co-occurring mental illnesses with substance use disorders, and actually provides you like case studies and how a student or a patient might present, and walks through the processes with how to best address that. So again, it's called Co-Occurring Mental Illness and Substance Use Disorders, because I don't see the question right now, but I think it was for an LMFT specifically. So that might be a good resource for you.
Awesome. Well, Alex and Tyler, thank you so much. Unfortunately, we've run out of time. I feel like I know a session went well when it feels like 20 minutes later, it's an hour later. So thank you so much. I know if we were in person, you wouldn't be able to hear me, but just because of applause. So thank you so much for sharing of yourselves. I know this work is very personal work. And so thank you for sharing of yourselves today. We really, really appreciate it. So much information was shared, and we really, really appreciate it. So just a couple updates of things that are coming on. You can see on the slide some upcoming learning collaborative sessions, water cooler chats, webinars. We have our cannabis symposium. So the last two are save the date. So please circle those dates on your calendar if you can join us. The cannabis symposium is a virtual event. So it's a most of the day virtual event. So please mark those dates, and we hope to see you at a session coming soon. So thanks so much, everyone. Greatly appreciate you being here. And one final thanks to Tyler and Alex. Thank you so much. And we hope to see everyone soon. Take care and have a great rest of your week.